Every great journey begins with a single step, and the road to UIP Buenos Aires 2025 starts now. On March 8th, we take the first step, an exclusive webinar on lipedema and lymphedema. Participate, learn from experts, and be part of something bigger. Prizes, recognition, and knowledge that will shape the future of venous health. And this is just the beginning. Many more events are yet to come. Be part of the journey. Secure your spot now. See you on the road to UIP Buenos Aires 2025. But this journey, it's about more than knowledge. It's about the experience. Buenos Aires is waiting for you. A city full of history, culture, and innovation. A city where tradition meets the future. And beyond Buenos Aires, Argentina offers breathtaking landscapes and unforgettable adventures. From the vibrant city lights to the wonders of nature, your journey to UIP Buenos Aires 2025 will be an experience of a lifetime. Join the greatest minds in phlebology, lymphology, and athletics. Learn, collaborate, and innovate alongside world leaders in venous health. Your journey starts now with On the Road to Buenos Aires 2025. Exclusive webinars, cutting-edge research, and real-world training. And this is just the beginning. What happens next will change everything. Pre-register today, secure your spot, and be part of history. The future of venous health is waiting for you in Buenos Aires.
Understanding these pathologies well. First of all, about the terminology. The old syndromic nomenclature was changed, and most important, it also was changed the core term of pelvic venous, chronic pelvic venous pathologies from pelvic congestion syndrome to pelvic venous disorders. And new classification to SVP, which means symptoms, varices, and pathophysiology, also was presented this time. It's a very great document and very good discriminative tool. It means that all pelvic and abdominal veins are divided in 4 zones. It's a renal veins, it's pelvic veins, it's extra pelvic veins, and the veins of lower extremity. For understanding and for classification of these veins, is presented 3 domains: symptoms, varices, and anatomy and pathophysiology. And this last domain also includes 3 subdomains, which is anatomical part, hemodynamical part, which case we have obstruction, reflux, or obstruction and reflux together, and also the etiology, which type of lesion are it's a thrombotic, non-thrombotic, or congenital. And very important studies was review studies was done by the international group about the identification of outcomes or clinical studies for pelvic venous disorders, and also the review about the scores or grading systems for pelvic venous disorders. Both these reviews show that these studies are heterogeneous, and it's difficult to compare each to other. But for now, we know which way are right for this, and we need the optimal scores or grading systems for pelvic venous disorders. To understand the best, how is the best outcomes, how to get best outcomes of the treatment. A very good study was presented in this period also by Dr. Ahmed Zianov in phlebolympology about the pelvic varicose vein questionnaire and also the pelvic venous clinical scale severity scores which were done based of the similar tools of the chronic venous disease of lower extremities. Of course, this product also need the future validation, but we think that it's a very good job, and it's will be a great base for future investigation. And a very important document was presented by our Argentinian colleagues and also the colleagues from Grupo Iberoamericano de Estudio Pelvico. It's an intersocietary Argentine pelvic venous congestion syndrome consensus, which is very informative document and need future analyzing. But we have a lot of unmet needs. First of all, we need the modern terminology used to describe the different condition of pelvic venous disorders. And of course, first of all, we need the new definition of pelvic venous disorders. We also need a large-scale epidemiological studies to establish real data on the prevalence of pelvic venous disorders. And we permanently and dramatically need to increase the awareness of pelvic venous disorders among both patients and the general population due to a high social significance of the disease. And we need to create a unified diagnostic protocol for pelvic venous disorders. And also we need to define the role of medical therapy in the treatment algorithm. And what is most important, we need modern protocol for invasive treatment, which will define indications for embolization, optimal equipment and materials, the need for stenting for the treatment of obstructive form of pelvic venous disorders, indications for the treatment of varicose vein, as well as the place of open surgery. And special attention we must pay to management of combined forms, reflux plus obstruction of pelvic venous disorder. And we need to create disease-specific outcome and quality of life assessment tools. And last, we also must pay attention to diagnosis and treatment of acute thrombotic lesions of pelvic veins. So, as Marshall Rosenberg, a psychologist, told, focusing on the unmet need, not the judgment, more likely to get the need met. Thank you very much.
Thank you, Dr. Sasa Lazarasvili, for a great presentation. Y continuamos la participación del Dr. Suat Dogan, profesor.
And now we will continue with our next presentation, representing the Ministry of Health and Health Sciences and representing the Guglian School in Ankara, Turkey. Please, Dr. Dugansi, go ahead with your comment.
Okay. Thank you very much, Lorena, for the kind invitation and for the kind introduction. Zaza, as we all know, that is a huge expert in pelvic area. He let's say, admitted a lot so far. And actually, we are also doing some projects together about with the complications. But actually, the pelvic venous problems is the I think the most complicated parts of the venous problems, because which I will actually tell you that, especially if you look at the its multidisciplinary part, especially for example, for the chronic pelvic pain. If you look at the gynecological part, at least there are five different titles like vulvodynia, vestibular pain score, clitoral pain syndrome, dysmenorrhea, and a lot of things. And if you look at the urological side, at least there are 10 different subtitles, and also there are some other possible pathologies like fibromyalgia, pelvic floor, muscle pathology. So there is a lot of complicated terminology related with the pelvic pain. So as Zaza mentioned on his last slide, there are a lot of things that still need to make a clarification between multidisciplinary way among with our gynecological colleagues, urological colleagues, and other possible colleagues like physical therapists and the other ones, even with the gastroenterological and musculoskeletal pain syndromes. So I think the most difficult part is to understand the pathology. I think the treatment is most simpler one, even it can be some complicated cases as well. But as Zaza mentioned very well, we need to clarify what is the real pelvic problem pathologies. And even as he mentioned about the patient-related reported outcomes, which I will mention, for example, for a just pain scales related with pelvic problem, there are maybe hundreds of pain scales like monodimensional pain scales, multidimensional pain scales, neuropathic pain assessment questionnaires. You can find nearly more than maybe 20 pain scale analysis. And if you look at the chronic pelvic pain specific questionnaire, there are for the pelvic pain and urgency, interstitial cystitis, bladder pain, actually the pelvic pain assessment form, there are a lot of again questionnaires. So if we look in details, we need a lot of mixtures from different part of the disciplines, and we will I think a little mixture of diagnosis and some reported outcomes. Actually, under the auspices of UIP, I think we should make a interdisciplinary meeting to come together with our other colleagues, and we should make and I think good clarification of the pathology together, and also the terminology, and also the questionnaires. This should be simplified for each discipline. Therefore, I am very grateful to Zaza for highlighting such type of good unmet points, and I think we should come all together to clarify the pathology to help our patients having issues related with pelvic vein problems. Thank you very much for inviting me, and I wish all the best for 2025 meeting in Buenos Aires.
Bueno, ahora vamos a presentar.
We will now introduce Dr. Oscar Gural. He is our current president of the Inter-American Group in Pelvic Studies, and he will be speaking on pelvic reflux diagnosis and technical notes. Dr. Gural, you have the floor.
Buenos días, si me permiten compartir. Bueno, preparándonos al Congreso en Buenos me pidieron que hablara de desórdenes venosos pélvicos congestivos, cómo abordar su estudio. Entonces me voy a referir porque no sé si están escuchando la traducción.
Sí,
¿O no?
la traducción, por favor, al inglés.
Bueno, entonces muchas veces vemos el 30%
So many
del
times
problema.
we see only
Y este
30% of the
30% del
issues, and
problema
this 30%, like the tip of the
representa
iceberg,
70% de la
represents
patología desconocida,
70% of
que es
unknown
pélvica.
pathologies,
Esa
pelvic
situación pasa
pathologies.
desapercibida.
This
Nos
situation
enfocamos a un
is
30% del problema.
goes
Son
by
pacientes que
unseen.
experimentan
So
dolor
these
pélvico
are
de más de
patients
6
that
meses de
have
duración,
6-month
con dispareunia
evolution
intra y
pelvic
postcoital en
pain
algunas situaciones, a
with
veces hasta
intra and
extremas, la
post-coital
presencia de varices
dyspareunia,
vulvares
presence
y
of
multiparidad.
vulvar varices
En algunas
and
situaciones, aunque encontramos pacientes
multi-parity,
lubricadas.
although
También
patients
debemos
that
prestar
have
atención
not
a la presencia de
given birth
recidivas
also have
varicosas,
these
pacientes que
issues.
experimentan que
We
fueron
have
operados en
varicose
múltiples
atypical
ocasiones,
varices with
que pasan de
multiple
especialistas en
surgeries
especialistas
going from
sin
specialist
poder
to
resolver su
specialist
patología.
without solving their pathology.
Ya hemos visto de que muchos de los
We've already
síntomas
seen that
no
many
se
of the
deben solamente a
symptoms are
dispareunia, a
not
varices,
due to
lubricación atípica,
varices or
sino también
dyspareunia or atypically
estreñimiento, disurias,
located
pesadez
varices,
en
but
miembros
also
inferiores. Y para
dysuria,
esto, como presentó
heaviness
nuestro
of
colega anterior,
lower
existe un
limbs.
puntaje y
And
una escala
there's a
de severidad.
score and a scale, a
El
severity
sustrato
scale
de la
for that.
enfermedad
The
pélvica dentro
substrate
de los
of
conceptos del
pelvic
grupo
disease
iberoamericano
within the
se basa en la
Ibero-American
hipertensión venosa
group
pélvica y eso
concepts
se puede
is
ver a
based
fenómenos de
on
reflujo o a
pelvic
fenómenos
venous
compresivos o
hypertension
a
due to
situaciones
compression
glúticas.
or
Y esto
reflux
lleva
or
a
a
la
combination.
situación
And
de
this
éxtasis
leads
venosa
to
y a los reflujos.
venous
Todos los pacientes dentro de
ecstasis.
nuestro protocolo
And
son sometidos
all
a
of our
3
patients
ecografías
are
de miembros inferiores,
subject to
transvaginal y
ultrasounds,
ecografía abdominal,
transvaginal, abdominal, and lower limb
donde podemos
ultrasound,
identificar,
where we
asociado a
can
la clínica, la
identify and
presencia de
associate to
fenómenos
the clinic the
compresivos o
presence of
congestivos.
compressive or
Todos son
congestic
sometidos a
phenomena. All
flebografías
of them are
y
subject to
tomografías solamente en los
phlebographies
cuadros
and
compresivos.
CTs only
Ante
in
un cuadro
compression
compresivo que requiera
cases. If
tratamiento, se
there's a
procede a
compression
hacer el
case that
stenting
requires
y ante un
treatment, we do
reflujo,
the
la
stenting, and
embolización.
if there's reflux, we
El
do
examen semiológico
embolization. The
asociado a las preguntas que
semiological
hacemos al
examination
paciente es
associated to our
fundamental porque
questionnaire
podemos
is
identificar
essential,
muchas
and
veces
there
con
we
la
can
simple semiología
identify with just
la presencia
semiology
de lo que se
the
consideran
presence
los
of
puntos
what
de
we
fugas
believe
pélvicos,
are the
como
pelvic
el punto
leakage
inguinal,
points,
el
such as
punto
the groin
obturatriz en la
point, the
parte del
obturator
labio mayor,
point
el punto
on the
pudendo en
major
la parte
labia, the
posterior del labio
pudendum
mayor,
point on the
el
posterior
punto
side of
glúteo
the
superior
major
y el
labia,
punto glúteo
the
inferior.
upper gluteus point, and
Como
the
dijimos, el
inferior
examen
gluteus
semiológico
point.
muchas
As we
veces
said, the
requiere de la
semiological
colaboración del
exam
paciente,
requires the
donde
patient's
muchas veces la
collaboration.
presencia a
Many
veces de la ropa
times, the
interior
presence
nos
of
puede
underwear
dificultar
can
identificar
make
el
it
origen del
difficult for
punto
us to
y fíjense
identify the
cómo cambia
origin.
el examen
And you
cuando
can see how
tenemos
the exam changes
identificado el
when we
punto, en
can
este caso
clearly
un punto
identify the
pudendo y un
point.
punto
This is the
obturatriz.
pudendum and the
Actualmente
obturator
contamos con
points.
tecnología como
We
Vein
have
Viewer
the
que también nos
technology such
facilita
as the
dicha
vein viewer
visualización.
that
En
enables
algunas circunstancias
visualization. In
pedimos
some
colaboración del
circumstances,
paciente
we
que nos
request the
ayude
patient's
a identificar, por
collaboration
ejemplo, el punto
for them to help
clitoridiano,
us identify the
varicosidades en el canal
clitoridanian
del lock y
points,
también la presencia
the
de varices
lock
en lo que
channel
serían labios menores.
varicosities and varices in the
Es
minor
fundamental el
labia.
trabajo multi e
It is
interdisciplinario y
essential
esto
to
lo hemos
have a
aprendido
multi and
del doctor
interdisciplinary
Ángel
approach.
Sánchez,
We have learned this from
donde
Dr. Ángel
de Javier
Sánchez,
Leal y de Álvaro Sánchez,
Javier Leal,
donde
and
existen
Álvaro
4
Sánchez.
patrones de
They show that
identificación en
there
la
are
ecografía. Un patrón
4
normal,
ultrasound
un patrón de
patterns. The normal
insuficiencia que
one,
ante
the
la avanzada se genera el
insufficiency
reflujo, un
pattern
patrón
with
derivativo que
reflux,
tenemos
the
un hiperreflujo que
derivative
desaparece en la
pattern where we have
valsalva y un patrón
hyperflux
mixto.
that disappears
Hoy en
in
día con las
Valsalva, and a
reconstrucciones
mixed one.
3D
Today,
tomográficas
with
es posible
3D
identificar
CT scan
justamente estos
reconstruction, we can
cuadros
identify
congestivos
the different
y
congestive
podemos
situations,
no solamente
and we
identificar
can not
congestivos,
only
sino también
identify
compresivos
congestion, but
y
also
ver las variaciones
compression,
de
and
división de la
see the
aorta y los
different
sitios de
aorta
compresión que
variations and the
pueden
compression
presentar estos
sites that
trayectos
can
venosos.
enable the
Pero es
vein
el gol estándar
trajectories.
del estudio de los
The
pacientes
gold
de la
standard
congestión
for the
pélvica del
study
desorden venoso
for
congestivo
pelvic
es la
congestion
radiología.
and
El
congestive
abordaje lo hacemos
disorder
con
is
brazo derecho,
radiology. We
muy
do
pocas
it
veces por
through
yugular,
the right
solamente a nivel
arm, not
femoral.
many
El
times through
abordaje
the
lo hacemos en
jugular,
vena
femoral
en vena renal
only with
retroaórtica.
the
Anulamos la vena renal izquierda,
retroaortic renal
la vena
vein.
gonadal
So
izquierda,
we
la vena gonadal
use the
derecha,
gonadal
el
left
eje ilíaco
vein, the right
derecho,
gonadal
las ramas de
vein,
la vena
the
ilíaca
right
interna
iliac
derecha,
axis,
el eje
the
ilíaco
internal
izquierdo y
iliac
las ramas de
vein
la vena
branch,
ilíaca
the
interna izquierda.
left iliac
Posicionados en la vena
vein
renal,
and
podemos
branch.
identificar si existen
Positioning
cuadros
ourselves
de
on the renal
compresión.
vein, we can
Lo hacemos por
identify whether we have
flebografía, estudios
compression, and we do
rotacionales,
this with
con técnicas de
rotational
subtracción. Y quiero
studies phlebography, subtraction techniques, and I think think that IVUS is essential. We can also identify different compression patterns. This is a prospective protocol of over 10 years. We are doing an analysis of the renal vein derivative pathways. We have identified 7 patterns, and we are about to publish it. We can identify the nutcracker syndrome, which is the renal vein compression with a peak sign, ascending and descendant derivative pathways. Then we can go to the right gonadal vein, and with the Valsalva, we can identify reflux and repatency of the round ligament. And you need to pay attention to the internal iliac vein branches, the obturator vein, the inferior gluteus vein towards the head of the femur, and the upper gluteus vein in the arch of the iliac crest, the internal pudendum, the uterine vein, the classic one with a J shape, and the cervical vaginal complex, which are responsible for intra and postcoital dyspareunia. And we can find the correlation between the clinic, the ultrasound, the CT scan, and phlebography, which is the groin or inguinal point, which is the consequence of insufficiency of the gonadal axis. This is a typical example of a bilateral inguinal point through the repatency of the round ligament in a bilateral manner. Other examples of the inguinal point, you can see reflux is characteristic here, the internal pudendum point or the internal pudendal vein that follows the pubic crest or the pubic edge on the posterior edge of the major labia. These are examples of the internal pudendum points. This is the obturator point, which is one of the simplest ones. It goes through the obturator hole in a centrifugate manner, so we can identify the obturator reflux. And these are examples of the obturator points with atypical trajectories. The inferior gluteus points to the posterior side of the thigh, upper gluteus points, and these are the atypical varicosities that patients show on the posterior side as a consequence of the patency of the sciatic or the sciatic vein. And this is very characteristic. It's a patient with atypical varicose veins, but she has reflux of the inferior gluteus that generates varicosities that manifest on the posterior side of the thigh. And in light of Valsalva, reflux reaches the foot. So these are truly extreme situations. This patient is on an ambulatory manner, and her problem will not be solved if not done differently. And these are all of the leak anastomosis. And this was atypical varicose and dyspareunia, no pelvic pain, at least not permanent, only dyspareunia. And you will see the insufficiency of the vaginal plexus that justifies the situation. This is the map of all of the internal iliac vein branches that we need to assess, and in one same patient we can find all of the leaks. And that is why it's so important not just to look for the gonadal axis, but also the internal iliac branches. These are the primitive and external iliac veins with the Valsalva study, subtraction, rotational, and IVUS, and we can identify the different compressive or compression pictures. 40% of the population has vein compression, remember that, and these studies are done with different maneuvers, and ultrasound are made in standing position, sitting position, or lying position to see whether they're transient or permanent. Raju had this classification. We're not talking about May-Turner, but rather non-thrombotic iliac lesions to the right or left. And the assessment of that is really important, and that is why it's so important to have rotational studies and IVUS so that we can identify compression sites. We have different criteria to determine whether compression is important or not, and sometimes these compression of the iliac vein generate secondary pelvic compression, which is what the patient manifests. There are some other situations where post-thrombotic syndrome and obstruction of the iliac or the cavum generates pelvic derivative pathways that generate the symptoms, such as in this case where the patient referred pelvic congestion secondary to post-thrombotic syndrome and obstruction of the iliac axis. So the ideal thing would be to treat our patients with all of our planets aligned, like we had recently, where all of the planets were aligned. That is to say, the semiology, the clinic, the ultrasound, the radiology coincide, and this is possible. Yes, it is possible. We can do this with enough training, with a multi and interdisciplinary work that we are now doing with our Ibero-American team, training our colleagues to have accurate diagnosis to get the best results. Thank you very much, and we hope you can come down to Argentina in 2025 to our Congress. Thank you.
Thank you for an excellent participation. It's a part of what you will see in Buenos Aires. And now, Luis Rodriguez will make a comment, President of the Association of El Salvador. Luis Rodriguez, you have the floor. Thank you, Lorena. Thank you to the Executive Committee. It's an honor to promote this road to Buenos Aires 2025, and on this road, showing the excellent work done in Latin America. Those that recognize the most the effort and pelvic venous disorders. And of course, the protocol that you have presented is remarkable. And in these congresses, we seek to reproduce that type of work, the diagnosis as you specified. And I would like to make advantage of this opportunity to make questions to Oscar. What Dr. Gural has and shows is the final ultimate target. Very interesting to have centers for pelvic venous disorders, having reference centers in each area that are well trained with Dr. Gural group. A question for those that the most frequent they can see approaching the topic, because when we talk about venous pelvic disorders, we are talking about other type of thrombotic and non-thrombotic conditions. A question, the approach is vulvar approach. A good percentage are not related to pelvic pain. They are just related to the gynecologist tells them to seek care because it is difficult. We should integrate proctologists or urologists because this is a system. As long as we do not have the connection, we receive patients with pelvic varices. What do we do with the patient with pelvic symptoms? We apply the same protocol to the patients that have varices but do not have pelvic pain, or patient that comes because it says, I have this vulvar condition. Is there a change in the protocol depending on that? Because when we have pelvic pain, yes, that warrants many things. But when the pelvic pain is not related, extra pelvic manifestations in venous disease is part of the same protocol. Well, thank you. The most important is to work applying a protocol so that all patients, if they have symptoms or not, are managed in the same way. And the protocol needs needs to be repeatable. And the group is working in different countries. We always do it the same way. The questionnaire should be detailed, not only 3 questions. You say perhaps you do not have pelvic pain, but yes, dysuria, constipation, abdominal distension, heaviness, or that refers some time of a postcoital pain. So sometimes the questionnaire, detailed questionnaire, permits to identify that. That sometimes is not veiled for not seen by gynecologists or obstetricians. Also to explain that vulvar varices are not normal. Some has it after 3 pregnancies, it's normal to have varices. No, it is not normal. So the vulvar region is divided into clitoris, the endpoint of the pudendum vein, the midpoint, and the pudendum point. So there are 3 veins that are diseased, and you see vulvar varices. So we are only seeing 30%, and then 70% will have reflux, and the reflux needs to be treated. There are techniques like Franceschi, external sclerosis to treat the leak. We apply endovascular technique. But what is important is the questionnaire, the transvaginal ultrasound, where it is so simple. Sometimes in 10 or less than 1 minute, you can have a diagnosis where if you count more than 5 venous lacunes measured in more than 6 millimeters and having a change of color in the Doppler, in Doppler, you can identify reflex. It's a very simple method. And then training, I think transvaginal ultrasound exists all over the world in all hospitals. So it's just a matter of training those that do image diagnosis.
Gracias, Dr.
Thank you.
Vamos a tener la
And
participación del
now
doctor
we'll have the
Sergio Gianesini,
participation of
para
Dr. Gianesini
un comentario al
to
doctor.
make a comment.
Lovely talk as always. I'm a
Excel.
bit confused on where we stay in pelvic venous disorder with the thromboinflammation of the reflex. If you think about the lower limbs, we know already that a reflex is associated with 5 times the risk of developing a deep venous thrombosis. But we generally don't talk that much on how we should put a thromboprophylaxis on these patients. So in your vast experience, do you consider pelvic venous disorder patients as at risk of developing thrombosis? Do you have special care in them, and what kind of thromboprophylaxis you use after these procedures? Because up to my knowledge, there is no real consensus on this topic.
Buenos días, Sergio. Gracias
Good
por la
morning,
pregunta.
Sergio. Thanks for the question. We do not consider the pelvic venous disorder as a prothrombotic factor. But yes, we have seen in ultrasound diagnosis thrombosis, for example, ovarian rami or uterine rami. Evidently, stasis produces thrombosis and is also responsible for many of the acute symptoms. If a patient goes to an emergency because of acute pain and had a thrombosis of the ovarian vein, we see more and more frequently those situations. I think we should change our approach. I think, as it appears in lower limbs, paying attention to these disorders may cause thrombosis, and we see it when treating patients. We want to obstruct these transects, and yes, we do embolization. We do not use thromboprophylaxis. On the contrary, we avoid thromboprophylaxis to have a better response. But with the use of Varixio, we have seen with foam, when it acts distally, we can see more characteristic symptomatology of thrombosis. So obviously it's a chapter that is not advanced, that hasn't been studied, and I think it is interesting to pay attention, talk to hematologists and in image diagnosis, not to look for reflux only, but also thrombosis in these venous lagoons.
Thank you so much.
Muchas gracias. Y seguimos Con la participación del doctor Álvaro Sánchez Galán de España, cirujano
Álvaro
vascular del
Sánchez
Hospital
Galán
Argentina
from
Internacional,
Spain,
y parte del grupo
and who is
iberoamericano
part
de
of the
patología
Ibero-American group of pelvic pathology. Good morning. Good afternoon in Europe. Thank you for the invitation. Again, congratulations, Oscar, for what has been achieved. It's very important that the pelvic disorder in the congestive portion, we combine both situations, but as Oscar said, what we need to have clear is that manifestations is the reflex is valvar, and I am sorry, I can hear very low sound. In these cases will relapse. I think it's very interesting, the question, although it's important to publish patients with chronic pulmonary that had pelvic varices, and the cause was a chronic pulmonary embolism, and had respiratory relapse and respiratory disorders. And she was embolized, and then the situation was not repeated. So it's one further cause to consider. For the rest, it's a pleasure to participate and learn more about these pelvic disorders.
Gracias, Álvaro. Sasa.
Thank you, Álvaro. Sasa.
Yeah, once more, very interesting presentations, and thank you very much to Oscar Ural with this very informative presentation. And we just look how important to make like this meeting to discussing the different topics of pelvic venous disease. And I hope after UIP 2025 in Buenos Aires, we also continue the collaboration between Ibero-American group, pelvic group, and European Pelvic Vein Alliance. I think it will be very informative for both sides. Now, with great honor, I want to introduce Dr. Mark Garcia with his presentation, Pelvic Reflux Treatment, Technical Notes. Mark is an interventional radiologist, founder, CEO, and medical director at Endovascular Consultants. Please, Mark.
Thank you, Zaza. It's great to see you, and thank you everyone for the invitation. It's an honor to speak to you about pelvic venous reflux and the technical notes with this. Let's see, trying to get the I'm having difficulty with them advancing. I apologize.
¿Podemos poner el video, Fanny?
Puedes volverla a subir, sacarla y volverla a subir, Mark, a ver si es posible.
Okay,
Dr. Garcia.
Yep. Okay, I'm ready. Sorry about that. These are my disclosures. So talking about pelvic venous disorders, it is vitally important to understand the normal anatomy, the anatomic abnormalities, and the pathophysiology associated with those anatomies.
Mark, we are not seeing your presentation.
Okay.
Logro ver.
It says I'm sharing screen.
No, it's okay.
It's okay.
Sorry.
Maybe it's a problem for Lorena, but
It's
you're on.
okay.
Okay.
You're on, Mark.
Okay. So again, when we talk about pelvic venous disorders, it's vitally important to understand the normal anatomy, the anatomic abnormalities, and the pathophysiology associated with those anatomy. There are two normal pelvic venous drainage pathways. There's the primary pathway, which is the internal iliac and the ovarian veins. And then there's a secondary pathway, which include the common iliac, the IVC, and the left renal veins. The two pathologies that are associated with creating pelvic venous hypertension in the primary anatomy is reflux, and in the secondary anatomy, it's obstruction or compression. That primary abnormality with reflux is because of absent or incompetent valves that cause the insufficiency that are located in the gonadal veins, the internal iliac veins, and these escape points that you heard previously. When we talk about the obstruction or compression areas, these are causing outflow resistance leading to the venous hypertension, and they can then cause varicose collaterals. And these areas include the May-Thurner syndrome with the iliac, the Nutcracker syndrome with the left renal vein, the Rokitansky lesions with diffuse iliac stenosis, usually from post-thrombotic disease, and then IVC obstructions. So when to treat these patients is when the patient's symptoms are related to anatomic pathology and the symptoms are significantly affecting quality of life. Remember, there are lots of patients with anatomic abnormalities, such as May-Thurner, that have no symptoms whatsoever. So just because it's there doesn't mean we should treat it. Most treatments up to this point have really focused on gonadal embolization alone. And as you heard earlier in these talks, excellent talks, this is a very complex situation. So my first tip is focusing on gonadal pathology and treatment alone will lead to many treatment failures. The initial evaluation should always include all of the primary and secondary anatomy, looking for both reflux and compression. When we talk about the reflux evaluation, it's through venography. You need to do selective venography in both the both iliofemoral systems from the common femoral level. You need to look at the internal iliacs, both renals, ovarians, and the IVC. These injections should be performed on a tilt table in reverse Trendelenburg. If not, then you have to have the patient Valsalva. And if you need to, you can use a balloon occlusion catheter, which will help augment filling of the varicosities and the extent of the disease. And these can all be done from a single access. So my second tip is you need to use venography for the reflux evaluation, but intravascular ultrasound is critical for evaluating compression. Once we've confirmed that there are anatomic abnormalities associated with the patient's symptoms, how do we present treatment? Well, as you heard from Zaza, there are many unanswered questions. What is the optimal treatment priority? Do you treat reflux first or obstruction first? What is the best embolization techniques? Is it coils, glue, sclerotherapy, a combination? What are the indications for treating a venous stenosis? And how to best treat a left renal vein stenosis if needed? Do you use stent or use surgical reimplantation? So here's my algorithm. I do the initial selective venography of the anatomy that we talked about, including IVUS of all primary and secondary anatomy. I do treat the reflux first by placing a microcatheter via diagnostic catheter into the low pelvic varices. I sclerose the pelvic varices first. I inject slowly, and we're going to get into the combination of what we use here, but inject slowly until the entire plexus is covered. I then embolize the ovarian vein using a sandwich technique. I coil low, sclerose in the middle, and then coil or plug up high. I want to evaluate the internal iliac veins and look for the treatment of reflux if present, which oftentimes can show these escape points that need to be sclerosed. I then follow up in an office with a reevaluation in 4 to 6 weeks. Usually I'll get a report from the patient that there's 70 to 90% improvement. And if they don't have improvement, it's oftentimes the legs that they're complaining of that are persistent. I treat iliac vein compression next with stenting. If the significant residual symptoms are present, I do a repeat intravascular ultrasound to confirm it. stent across the entire lesion. You do not want to leave any part of that lesion uncovered. They will fail. And then I put them on dual antiplatelet therapy for 3 months. And I will lastly treat the renal vein compression if needed. And I got to tell you, in my 30 years, that's been rare that I've needed to do that. The guidelines for sclerosis, there are a variety of concentrations and mixtures that have been described in literature. What I do is when I get into the pelvic veins, I usually use Sotradecol 3% with a gel foam slurry with some contrast so I can see this as I inject, and I fill that entire pelvic venous plexus. With the larger veins, I then also use 3% Sotradecol slurry. I embolize low, as I mentioned. I do the sandwich technique where I'll inject the Sotradecol in the mid portion, and then I plug up high. In the small veins, being the labial and escape points, I use a 1% sclerosant foam or liquid with some contrast. I do it under fluoroscopic guidance, and I treat up to the round ligament. When you do this entire sclerosis, you can expect inflammatory reaction and pain, and I usually treat this with the nonsteroidals and a steroid dose pack, which usually is all patients need. When we talk about the periuterine plexus treatment, there's a third tip here, and that is to treat the entire plexus. If you do incomplete elimination, it could lead to incomplete response and recurrent symptoms. When we do sclerosis also of this area, you may find that the outflow washout is very rapid and you have difficulty controlling stasis. Then you would use balloon-assisted sclerosis. You inflate the balloon and inject through that lumen in retrograde fashion. Again, using 3% Sotradecol with the contrast and slurry that I talked about. And you want to leave that sclerosis in that pathologic varicosities for 5 minutes for its best outcome. When we talk about embolization of the larger veins, which is really the ovarian vein, as I mentioned, I do an occlusion device such as the coils down low. We embolize both low and high with coils, and then up higher with the plug or multiple coils. The next tip would be you need to oversize your occlusion device per the IFU to prevent migration that can occur. We mentioned parallel pathways. They are commonly seen in the ovarian vein, and they will continue to fill the plexus if they're not completely eliminated. So incomplete elimination will cause continued response and recurrent symptoms. So the sixth tip is occlude all these parallel pathways. Again, I do this with the sandwich technique, coiling low, sclerose in the middle, and then occlude high. That usually takes care of it. You want to make sure you pack your coils very tightly to help prevent migration and leaks. Lastly is the labial veins. Just as an anatomic reference, Mel Rosenblatt's rule was to treat up to the round ligament, and these are just some anatomic images to show you. And then Mel gave this image that shows when you inject, this star is showing the round ligament that's actually refluxing down inferiorly into those escape points. Here are some other pictures from Mel that you can see from a pelvic injection, labial injection. You'll see the varicosities extending and ascending into the round ligament, which is this C-shaped structure. That's where you want to sclerose up to that point. So when we talk about labial sclerotherapy, I do this under direct visual or, if needed, ultrasound access with a 25 gauge needle. We inject under fluoroscopy with some contrast to identify the anatomy. And sclerose, I use 1%, which is 3% diluted to be 1% with contrast. You can use a foam or liquid and treat up again to the round ligament or until you start to see normal veins. And you want to make sure you treat all the veins involved with the symptoms, including the escape points, as mentioned recently. In conclusion, pelvic venous disease the treatment should be tailored to the patient's symptoms and anatomic pathology. You have to look for both reflux and obstruction. I treat the reflux first with the periuterine veins being treated first with sclerotherapy using a slurry with 3%, the gonadal vein with the sandwich technique with both occlusion devices and the sclerosant to make sure we get the parallel pathways. You want to treat the labial varicosities under fluoroscopy and treat up to the round ligament. And then lastly, you want to treat obstruction and compression. I do it secondary after reevaluating the patients 4 to 6 weeks later and determining even if they need to be treated whatsoever. And again, you really should treat this with or evaluate this with IVUS to get the best diagnostic evaluation and make sure that you're treating the entire lesion in its entirety. We didn't get a chance to talk about the obstructive or compression lesions. Again, I just want to mention IVUS is the gold standard, and you should be looking at the iliacs, not just the classic May thinner left-sided, but the variations of both left and right, as well as diffuse Rokitansky lesions. And then again, the nutcracker left renal vein compression in addition to the IVC issues. Just a picture of IVUS that's showing the compression. And thank you very much for the honor to talk to you.
Yeah. Thank you very much, Mark. Excellent presentation. And before we hear the comments from the experts, I have one question to you. There's some different approaches for today in a treatment of complex combined lesions. When, for example, we have the nutcracker syndrome and pelvic reflux, and on another side, left iliac vein compression, and again the pelvic reflux in gonadal veins. There's a different approach in the case of a combination of nutcracker syndrome is first to treat the reflux in this case, in the theoretic mismanagement. In case of May-Turner syndrome or like iliac vein compression syndrome, the main authors recommend to treat at first the compression lesion and then wait how the clinically with that. What is your personal experience? Which is better? How to do in this case?
Yeah, and I think this is thank you, Zaza, for the question. I think this is why we need to have a combined, really extensive, thorough research on the best way to go. Because many of the patients are young that I treat, I try not to want to put in a permanent implant in them if not necessary, which is why I made the comment that oftentimes I'll see from just treating reflux alone, even though there is May-Thurner compression, and oftentimes there is, I would say more often I see that in combination. But excuse me, I would say that there's probably 30 to 40% of the women that I treat that don't need an iliac stent, even though it's there. They feel fine. They feel great with what it is. And that could last years. So I don't treat the iliacs just because they're there. But again, if they come back and follow up and they still have lower extremity or pelvic symptoms, I will approach the next step with the iliac vein stenting.
Yeah, thank you very much. And now I want to introduce Dr. Tea Muhuradze from Georgia to make a comment about your presentation about the treatment options. Please, Tea.
Thank you, Dr. Zaza. Hello, everyone again. First of all, I want to express my gratitude to everyone for their time and effort in making this great webinar, which is ahead of the UIP World Congress in Buenos Aires. And it's a fantastic opportunity for us to gather insights and prepare for this important event. I truly appreciate the hard work that went into assembling such a knowledgeable group. I would extend my thanks to previous speaker for their engaging talks, and of course our wonderful moderator for their guidance. And special thanks goes to Dr. Garcia for this excellent presentation. It was incredibly informative, and I really appreciated the clarity which you explained all the technical aspects. And all the tips you shared were particularly insightful, and they clearly outlined the underlying mechanisms which are crucial for improving treatment's efficacy. And I have a few questions that I hope you could elaborate on. Okay, my first question is regarding the procedure. What is the most significant technical challenges that you faced during this treatment, and how do you recommend overcoming them? And my next question is regarding the specific patient demographics, or is there any clinical presentation or special variation in venous anatomy that are more likely to benefit for this procedure? And at the end, what do you see at the next big breakthrough in pelvic reflux treatment? Are there any emerging technologies or any techniques that you can find particularly promising in future? Thank you again for your excellent talk.
Well, thank you for the questions. From the first question, the difficulties, the challenges, I think I'll use actually an opposite correlation here first. It's amazing how many women, when they get evaluated in the office, cry because they find out that they're not crazy. And that is one of the best feelings, to let them know that whether it's, postural orthostatic hypotension that they've been diagnosed with, that they've told there's no real, they've been evaluated by cardiology and there's nothing else. And then we find out that they have, the extensive pelvic abnormalities, and other women who just think they're crazy, and husbands want to divorce them because they can't have sex because it's so painful. That's a true great feeling, to know that you've been able to benefit these women and have a much better quality of life. The challenges I find actually are sometimes before they get to me, which is getting the appropriate diagnosis. From the procedural standpoint, it's really just the challenge of the anatomy, just making sure that the techniques you use, do you come from the femoral vein, the neck? I heard one of the talks, they mentioned coming from the arm, which I've never done. But it's really just the anatomy and engaging your catheters to the right position and finding the anatomy and the abnormalities. Once that's done, I think the rest of it, as you've heard, you do the same thing over and over, you get better at it. And I try to treat everybody the same way, which is the techniques that I just spoke about. And by doing that repetitively, I find that there's less missed problems, missed anatomic abnormalities, and that I'm more thorough in my evaluation and getting better results. And I'm sorry, the other question you had asked?
The specific patient demographics or other variation of venous anatomy, which would be more benefit from this procedure.
Yeah, so
characteristics in this term.
Yeah, so the demographics are clearly, for most of my patients, are multiparous women. That is not the only, but that is the vast majority of them. Many of our women are actually very athletic. I have people who are runners and gymnasts and so on that are very athletic. And so the demographic is typically that younger population. And again, these women are suffering so long that I found that the treatment really does benefit them. And again, the key is being very thorough. It's just being thorough to look at all the reflux points, all the compression points, and making sure that you've pathed out what needs to be treated first, second, third, etc., and making sure they understand what the long-term goals are going to be and how we're going to get there.
Yeah. Thank you, Mark. In addition, I want to tell that there is in the treatment of our disease, there's two main challenges. Yeah, it's effectiveness and safety after this treatment. It's effectiveness. It's we all working that to make for each patient in the individual type of procedure, because the lesions are very, very specific and very individual in a patient. According to safety, we also working to use the new and different materials for the embolization, which the most important thing to avoid the migration of the embolic materials and the adequate embolization of the all necessary veins. I think this is the future directions in the for the treatment of pelvic vein reflux. Thank you very much, Mark.
You're welcome. Thank you.
Sam. Let
Yeah.
me ask una pregunta. Quiero hacer una
I have
pregunta
one question for you, Mark.
a Mark.
Yeah, of course.
Si es posible,
Is it possible, Mark, this question is for you. Based on your presentation, you talked about the treatment of varicose veins that are located
genital
on the
o
genital
miembro inferior,
area
en
or
la base
lower
del
limbs
muslo.
or on
La
the
realidad es
basis
que
of the thigh.
has presentado en tu presentación con
And in your
concentraciones
presentation, you mentioned
medicamentos detergentes
concentrations
que al 1%.
uh,
Sabemos que
of 1%.
estas punciones muchas veces
So
no
we
son
know
fáciles por la
that
región
these are
y
not very
para
easy to do because of the place where they're
buenos
located.
resultados tenemos
And to
que
get the best
tener una
results,
exacta
you need to
técnica, una exacta
have
aplicación
very
de la técnica.
accurate technique
En este
and
punto
apply
tengo
it very
dos dudas.
accurately.
Primero,
So I have two
¿cuál es el
doubts on
índice de
this.
oclusión que
What's the
nosotros podemos
occlusion rate
obtener
that we can
con estos
get
tratamientos desde
through
abajo?
the treatment coming
Si
from
crees que
down
son
upwards?
suficientes o
And
si
do you
tienen que
think that they're
repetirse
enough, or do we
como
need to
sucede con la
repeat them as it
escleroterapia
might
convencional,
happen with the
muchas veces
conventional
posterior al
sclerotherapy, that after the
ablativo en el
ablation
abdomen?
procedure in the abdomen,
Y segunda
we need
pregunta
to
es
repeat?
si tuviste
And the
complicaciones
second
sobre la
question is
piel
whether
de
you've
úlceras
had
producto
any
de las
skin
inyecciones
complications, ulcers, for example, resulting from
aplicadas
the
por fuera del
injections that you
vaso
applied outside of the
eliminación de las
vessel
sustancias
because of the
pegajosa.
migration of the substance out of the vessel.
So I'll answer the first question first. Thank you, Oscar, for the question. I've not had any ulcers, which is, I think, the reason why when we do it under fluoroscopy, particularly in that lower level, you are being very cautious and slow to inject, and the slurry helps a lot to control flow, so that as you do this under control with very small syringes, 1 cc syringes, where you can control the volume. You're not just injecting it hard, you're doing a very slow control. What I've also found is by treating the pelvic areas first, oftentimes if there is reflux, there's a technique that's used when we do prostate artery embolisation.
Se nos cortó, Marca.
Rose.
I think Mark froze.
Yeah.
Are you there?
Now, yes.
Okay, I'm sorry. What I was trying to say was that you do this under very controlled situations with a 1 cc syringe, and I use a technique that I use that has been described actually with prostate artery embolization, where you embolize first high and large, and then you sort of force the smaller particles below that, which is easy to do because you've already occluded the outflow. So if you address the pelvic, the peri-uterine plexus and the pelvic varices first with the bigger slurry, you can then get down lower and inject very gently with the 1 cc syringe with the 1% foam, with contrast, again, under fluoroscopy, and be very specific and detailed to the level that you're going to be. And I've not seen ulcers or non-target sclerotherapy or embolization using that technique.
Thank you very much, Mark. And now is the last speaker of our webinar today. It's Dr. Luca Gianaroli with the presentation about the pelvic pain differential diagnosis everybody should know. Dr. Gianaroli is a specialist in gynecology and reproductive medicine, director of global educational activities at International Federation of Fertility Societies. It's very important, our collaboration with gynecologists, for example, because if in management of some disease, the multidisciplinarity is a priority, in the treatment of pelvic venous disorders use the involving of the multidisciplinary team is necessary, extremely necessary. So, Dr. Gianaroli, we hear you. Yeah, please.
No, I think we have a recording message.
To the
He's here.
possibility
Okay.
to share with me pelvic pain as a differential diagnosis that everybody should know. As a gynecologist, I like to remind all of us the definitions of chronic pelvic pain, of pelvic venous disorder, and chronic venous disease, taking into consideration that at least 10% of the patients admitting to emergency unit in gynecology, they suffer because of chronic pelvic pain. And if the diagnosis is done correctly, up to 30% of these patients have a pelvic venous disorder. The chronic lower abdominal pain can be associated with dyspareunia, postcoital pain, lower back pain, bladder irritability, urinary urgency, and most of the time it's increased with intra-abdominal pressure, with prolonged standing, and with menstruations. The chronic pelvic pain has different potential causes: appendicectomy, appendicopathy, adhesions, endometriosis, adenomyosis, I'll go back to that, traumas, spine nerve problems, adnexal pathology like ovarian cysts, salpingitis, hydrosalpinx, and the pelvic venous disorders. What's happened? Generally speaking, patients go to the GP and the GP refers to gynecologist. The gynecologist, after a pelvic examination and an ultrasound done transvaginally, will just work for exclusion criteria because that's the only way to try to make a diagnosis. And so it's sent to the colleagues in order to specialize in orthopedics or the neurologist because of the pain, or the psychologist sometimes if the patient is almost unlucky, and very rarely to vascular surgeon, or if the patient is lucky, to vein expert. So the pelvic vein disease in our field can generate infertility because it's outer vascularization that can both act on the ovary, generating a diminished ovarian reserve, so an early infertility and an early potential menopause, or can act on the uterus. And in this case, the endometrial receptivity can be definitely damaged in a chronic way. Not only that, but it can also alter the microbiome. So that's again creating another form of potential problem to conceive. It also could work in increasing the risk of what we call ovarian hyperstimulation and the complication related to this. Ovarian hyperstimulation is a iatrogenic syndrome that I'm sure many of you do not know, but can create even life-threatening problem to the patients. It consists, in fact, in having ovaries that enlarge in a traumatic way. You can see here a section of RMI. Has been reported that the first time in 1960, and the first case in artificial reproductive technology has been reported 40 years ago. It consists on the incapacity of the ovary to balance via the vascular vessels the fluid that is generating the growth of the follicles after stimulation with gonadotropins. Complications could be very severe because it could be fluid collection in the abdomen, sometimes even in the chest, electrolyte disturbances, blood clots in large vessels, usually in the legs, kidney failure, ovarian torsion, ovarian cyst rupture and subsequent bleeding, breathing problems, and pregnancy loss from miscarriage or termination because of the complication. Sometimes, rarely, unluckily, the syndrome brings to death. So Even this could be once that ovarian output stimulation syndrome happens, that has an incidence of 1-2% of the treated patient could go to complications related to the pelvic venous disease. Plus, the chronic pelvic pain, as it was mentioned before, is a problem that can be exacerbated by BMI, by other comorbidity, by the age of the patients, by previous uterine surgery, by previous miscarriage, and also by hormonal replacement therapies that are usually done during menopause. But when these factors are combined together, of course, we have an increased risk of this symptom. And I was mentioned to you, when they are combined together, the risk of having the problem is increased dramatically every time that we sum up one of the complications. So pelvic venous disease is a problem, and inside the problem of the pathology, there is the problem that how much does the gynecology know about pelvic venous disease? Nothing. How much the gynecology would like to know about pelvic venous disease? As less as possible, because it's going to be a problem for him, potentially a waste of time, and not be able to do the diagnosis and so on. And even more important, where does the gynecologist? Nowhere. So that's the reason why I think that it's extremely important that gynecologists and experts in vein disorders work together to try to mitigate this, that in fact could be almost considered a pandemic. I hope we can further discuss during your Congress in Buenos Aires this topic. Thank you for your attention.
Thank you very much, Luca. It's very, very important presentation, and it's one to increase the awareness about the pelvic venous disorders, not only between the gynecologists, but also to other specialists. It's very important, and it must be our one of the direction for future. Now I want to invite Dr. Malouf from Australia, president of the Australian and New Zealand Society of Phlebology, for the comment. Please, Mark.
Thank you, Zaza. Thank you very much. Firstly, how enlightened was Dr. Luca? Thank you for being honest and frank and telling us that the gynecologists are not terribly interested in this disease, because it's true. All of us speaking on this webinar are familiar with the disease, and we're in a cocoon talking about this disease. But if you step back from that cocoon to the realms of chronic pelvic pain, which is a much bigger group of patients. 1 in 7 women have chronic pelvic pain. And if you look at all the literature about chronic pelvic pain, very little of it talks about pelvic venous disorders. Very little indeed. In fact, from the US site, one of the many US sites, from that group of chronic pelvic pain, they describe, this is from 2023, the 5 most common etiologies of chronic pelvic pain are irritable bowel syndrome, I doubt it, musculoskeletal pelvic floor problems, no, not in my book, painful bladder syndrome, not really, peripheral neuropathy, rare for pelvic pain in my opinion, and chronic uterine pain disorders. In a 12-page paper from NCBI, the bookshelf, 2 mentions only of venous disease. So we are a small player in chronic pelvis disease, chronic pelvic pain. We are a bigger player when it comes to the patients presenting with veins in the vulval area, all the areas we've been speaking about. We are bigger players because we're vein doctors. That's the group we see. we miss out on the pelvic pain group, which is massive. And if the gynecologist could tell us, or could refer us more patients or understand the disease better, we would like it. One question I have, Dr. Luca, is on infertility and what we should be saying to patients about infertility after our treatment. You said that pelvic venous disorders can cause infertility, but what is our advice on the ability to have children after the treatment, please?
Dr. Luca?
I think Dr. Luca was not able to be online, so we just will communicate this question. I think I also have to comment, and just to be short, I think it's very important, as just Mark Maloof just mentioned, and Luca in his presentation, to be aware that this is a very multidisciplinary illness that we have to approach this way. And for sure, we have to start thinking and do reflection if we have to start since the residency programs and our trainings, and give more a view about this gynecologist illness. Try to work together, no, in different ways. And this is so important. And since we are all together on different continents and of course different big names in this pathology, I think this is something that we have to think about. Thank you.
Sergio, please, you have some comments.
Yeah, just to say that this is a difficulty that becomes an opportunity to properly introduce Professor Generali in our community, because Professor Generali was meant indeed to give an honorary lecture, for which this was supposed to be just a comment, and also an opportunity to deeply thank Mark, who is the champ here, I think, because it's like, what, 1 a.m. in Australia. So being with us at 1 a.m. Really deserves an applause. Luca Generali is the Caprini, I would say, in the gynecology world. He's the one who basically brought in Europe the very first cases of fertility medicine as modern fertility medicine. And I think some numbers are very interesting for our community. 7%, but he might correct me, but he told me 7% of all the kids that are coming nowadays to life, guess what, are coming through fertility medicine. And then it's also interesting to remember that 3% of all the women going to the gynecologist for whatever reason are actually presenting a periuterine venous plexus thrombosis. 3% of all the women going to the gynecologist. So clearly we can help each other very well with giants like Generali, and it's very important that we understand from them the diagnostic, the differential diagnostic path we can take. And at the same time, we can help them, because he's really now interested in coming to our community and co-work with his community. So of course there will be a lot of global experts involved in this project. Generali was the president of the European Society of Gynecology, so he's very much engaged. I think he's in China now, so it's not that he doesn't care to be here. It's really impossible for him to be here, but he's extremely available, and I hope you will get the chance in Buenos Aires another occasion to meet him. So I think it's a very important project we are running as FLEBO BGYN altogether. And thanks again, Mark, for 1 a.m. performance. You look fresher than me.
Thank you very much, Mark. Thank you very much, Sergio. It's from my side, I want to talk. This is a very, very important issue, because the increasing awareness between the doctors is very important, and I think the one of the way can be the creating more extensively the special pelvic pain centers, which are in many countries, and also involvement in the working of these groups or centers, the specialists of different medical specialization. Ayman Fakhri want to comment. So please, Ayman.
Yes, thank you, Zaza. It's really my pleasure to join this great conference online. I think the gynecologist has a very big role in pelvic congestion syndrome, because these people who has the ability to do transvaginal duplex, they can do it simply, and they can imagine and see how many veins are there, and a lot of veins around the uterus and around the in the pelvic rim. They can get a direct clue, and they can expect the venous problem for their patients. Again, not less than about 15% of these cases underwent exploratory surgery for gynecological reasons. They have one element of pelvic congestion. I think it's time to go together hand in hand, because they have the tools, very small tools for every lady. They can put their transvaginal duplex and expect what's abnormal and start their investigation from this point. Thank you.
Thank you very much, Ayman. Thank you. Now, Lorena, please.
Yes. Tenemos unas preguntas y comentarios.
We have some questions and comments. Dr. Alfredo Prego from Uruguay for Dr. Mar Garcia. What can you attribute the persistence of symptoms after appropriate satisfactory treatment or the reappearance of symptoms?
Hi, Lorena. Thank you for the question. In all honesty, I think that the recurrence of symptoms are either because something has been missed or that there's been reoccurrence of reflux in areas that have been previously treated. That's mostly what I've seen. But the number one thing that I see is referrals that come to me after they've been treated by other interventional radiologists who have simply focused on ovarian embolization alone. And they ignore the nutcracker, they ignore the May Thurner, they ignore the other areas, and they're incompletely treated the pelvic varicosity. So that's what I've experienced, is just that it's usually incomplete. Rarely there's a recurrence, but it's, again, as we mentioned, both treating reflux and compression that gets the best results. And the results that we've gotten by doing that have been fantastic.
Muchísimas gracias.
Very interesting question.
También tenemos para una pregunta para el doctor.
We also have a question for Dr. Lazarasvili in connection to the diagnostic approach. In your opinion, the realization of duplex ultrasound in the assessment and diagnosis of patients with pelvic disorders varies according to demography and some clinical manifestations.
Bueno, contesto esta pregunta y si querés hago un aporte a la pregunta.
I will answer this question or will complete what Mark stated. In the group, the sandwich technique in our group is different. First, we inject foam, then coil, and finally foam for gonadal axis, and for differently than Mark, that use coil, foam, coil, foam, coil. Why do we inject foam first with Valsalva? Foam may disseminate distally, and that distal dissemination with Barixia permits to treat all those necrosities that do not reach the coil, where the coil doesn't reach. So there is more further occlusion at the level of escapes. The second point is why the symptomatology persists. Since we use foam first, there may be vasospasm and escape is not identified in the treatment. The other cause is that we forget to treat cervicovaginal vaginal plexus that is usually responsible for persistence of symptomatology. When we miss it, and then dyspareunia persists, postcoital particularly. As for the question, ultrasonography or transvaginal echodoppler does not present a demographic difference. At least we haven't found it. We're talking about an experience of over 40 years, started by Javier Leal Monedero
Abraham Lester en
and
Colombia,
Abraham Lester in Colombia, what has been seen
una mayor incidencia,
is
y
a greater
coincidimos con Marc
incidence, and we
García,
agree
en
with
las
Mark
múltiples.
Garcia in multiparous
Eso
women.
sí, se ha visto
This
una mayor
has been, we
dilatación
have
de
seen
lagos, una
greater
mayor presencia
dilation,
de
greater
varices,
presence of
y eso en
varices,
definitiva podría
and then
explicar
that might
justamente todas las
explain
variaciones hormonales que
all of the
presentan las mujeres
hormonal
durante el
variations
embarazo,
presented by women
aumenta
during
la
pregnancy,
laxitud y la
increasing
elasticidad de todo el
laxity
plexo
and
pélvico.
elasticity of the
Muchísimas gracias, doctor
plexus.
Ural. Y también nos
Thank you.
preguntan en la
And
actualidad y en el
at
futuro,
present
¿cuál
and in
sería
the
el rol
future,
del
what
glue
is the
en el
role
tratamiento
of
de la enfermedad venosa pélvica? Sería la última pregunta.
¿Para Marc o para mí?
For Mark or for me?
Le preguntan para Mark, pero
The question for
realmente
Mark,
cualquier aporte es favorable.
but anyone can answer.
Doctor.
Yeah, I'm sorry, but I did not get the question. It wasn't translated.
En la
What,
actualidad y en el
at
futuro,
present
¿cuál
and in the
considera usted que
future,
sería
what
el
do you
rol
consider is
del
the
glue en
role
el
of
tratamiento de la
glue
enfermedad venosa pélvica?
in the pelvic venous disorders disease?
Yeah. So years ago, I actually used glue quite often in the initial patients that I was treating. What I've found is that it's incredibly expensive. A small vial of glue can be $3,000, $4,000, $5,000 in the U.S., and that's only 1 ml. And so you can, treating an extensive pelvic plexus can take multiple vials, and tens of thousands of dollars can be used. So I sort of moved away from that, although it was very effective. The other problem was that women had more pain with glue than they did with the foam sclerotherapy in our experience. So although glue is very effective and it does a great job of embolizing permanently, it is expensive. And then in the initial presentation, like I said, after using it, it can cause a lot of pain.
Dr. Lazarashvili.
I have no personal experience in using of the glue, but of course I use the sclerofoam, and in some cases I also used the composite material like onyx, because it's mainly we use the liquid sclerosant in patients with reflux in internal iliac vein branches. I tried not to use in these cases the mechanical occlusion materials because to avoid the migration. And I think also the using of glue maybe in these cases may be a good choice. But it must be do very, very carefully to avoid the migration of the material of the glue.
Bueno, gracias. Ahora vamos a dar paso a el comentario final, el de
Now
cierre
the final
de
comment
Julián. Como
by
ustedes saben,
Julian. As you know,
es cirujana vascular.
she is a
de la
vascular
División
surgeon
de
of
Cirugía
the
Vascular y Endovascular
vascular surgery and in the vascular surgery division of Massachusetts,
General
at
Hospital
the
de Massachusetts,
Massachusetts General Hospital,
en
assistant professor in Harvard.
Doctora Julián, su
Dr.
comentario final.
Julian, your comment.
Good morning, good afternoon, and good evening. This is Dr. Julianne Stoughton from Boston, Massachusetts. I'd like to thank the organizers for having me and for putting together such a thoughtful and timely program on pelvic vein disorders. I'd also like to congratulate the speakers for hitting the most important points and to really solidify the needs, the diagnosis, and the optimum treatment of pelvic vein disorders. My final thoughts. I used to be worried about underdiagnosis, inappropriate, and undertreatment of pelvic vein disorders. But now that the patients and providers are becoming more aware, I worry about their overtreatments, misdiagnosis, and sometimes partial success because of the lack of a team approach. The last presentation, I find, is so important for us as vascular specialists to understand the gynecologic, the GI, and GU causes for pain, which are more likely in many situations to be the primary cause. We need not only to examine the imaging, but we need to really listen to the patients and consider all options before intervention. We should always be using the SVP classification system, which is about where the symptoms and the anatomy and pathophysiology of the veins that are in question to do the right thing. Finally, as a person who's treated many men and women over the years with chronic pelvic pain, I have to point out the importance of setting expectations and finishing the job. It's not over when the interventional treatment is done. The patients often have chronic myofascial pain, muscle spasm, and trigger points that need to be addressed to stop the cycle of chronic pelvic pain after we fix the plumbing. In addition, there's nerve desensitization, which can be a long-standing issue and needs to be addressed to truly help eliminate the patient's pain. Therefore, please remember to send the patients to a pelvic floor therapist who's familiar with these issues before and after their treatments to help them fully recover. It's not just putting coils or a stent into the patient. It takes a team to make the outcomes the best that they can be. Thank you very much.
Thank you. Thank you. And for the closing remarks, I also want to present my friend and very important, the convener of the UIP 2027 in Tbilisi, Professor Mamuka Bokuchawa, who is vascular surgeon, the director of Bohua Memorial Cardiovascular Center, and the past president of Georgian Association of Angiologists and Vascular Surgeons. Mamuka, please.
Thank you, Zaza. Hello, everybody. Let's begin my video and then several words additionally. Please.
My dear friends, dear colleagues, and dear Oscar, I extend warm greeting on behalf of the Georgian vascular specialists. Congratulations on the successful hosting of impressive webinar regarding the pelvic venous disorders. As we enter the final stage of our multi-year marathon, I am confident that with your support and the effort of our Latin American counterparts, the October meeting in Buenos Aires will be truly unforgettable. We eagerly anticipate it, especially as we prepare for the next meeting in 2027 in Tbilisi, where we aim to make an even greater impact. Also, the Congress in Georgia, which historically played a crucial role in the Silk Road, holds significant importance for the development of phlebology and lymphology in our region and West Asian countries alike. First step in this field was Silk Vein Road, international meeting in May 2024 in Tbilisi, capital of Georgia, with many international speakers and attendants. While I share this light-hearted remark, please know that we have always appreciated your unwavering support. Together, I hope we can navigate this challenging, your fascinating journey. Let's continue to collaborate. We are committed to hosting scientific webinars loading up to Buenos Aires, and we invite you to contribute your ideas and insights. Your participation will enrich our discussion and enhance our collective knowledge. Wishing you courage and endurance, I am optimistic that our joint efforts will yield great success in managing venous and lymphatic diseases to improve our patients' care. Thank you so much and see you soon.
Thank you very much, Mamuka. Thank you.
Some additional words. Thank you so much for this perfect webinar. Congratulations, Oscar, and my friends from Latin America. I would like to tell you several words, inscription from the coat of arms of the country of Georgia. Strength is in unity. That's why we are with you, Oscar, and our friends from Latin America. We will stay together. I wish you that the UIP World Congress in 2025 will be very impressive. Good luck, my friends. Good luck, my friends, and see you very soon. Thank you so much.
Thank you very much, Mamuka. Thank you.
Gracias, Mamuka. Ahora vamos a
And
completar
now
nuestro
we
cierre.
will close.
Invitarlos, por
I
supuesto,
would like to invite
resolver
you
y mirar la página
to
donde
visit
ustedes
the
pueden ver el
page
casillero, pueden
where
hacer un
you can
recorrido
see
virtual y
you
empezar a vivir
can
la
do a
experiencia de lo
virtual
que será el
tour
2025
and
y
experience
ahí vamos a estar
2025 World
ya trabajando
Congress,
para el
where we
2027
will be working for
Estos son los consensos
2027
latinoamericanos que
infertility.
estamos
These are the
estableciendo
Latin
con
America
una ruta
consensus
con la
we are
participación de más
establishing
de 35
with the
sociedades
participation of
latinoamericanas.
35 Latin
Lo que
American
buscamos, como
societies.
mencionamos antes, es que
What
las
we
actividades
look
tanto
for is the
multidisciplinarias
activities
como
multidisciplinary
multisocietarias
and
sean muy
multi-society to
activas
be
y
very
estén
active
en todas las
and
sesiones
be
durante
present
los
in
4
all
días
sessions
de
during the
trabajo
4
y durante
days
el
of work.
precongreso tengamos esta
And during the
actividad. Pueden
pre-congress,
seguirnos sus
you can
abstracts
write
sobre
to
todas
us,
estas
you can send your
temáticas
abstracts,
y pueden elegir
and
dentro de
you
la
can
página
select
cómo hacerlo.
how to do
Y
it.
recordar que tenemos dos
And
niveles de
remember that we have
presentación,
2
uno
levels
con
of
trabajos
presentation.
científicos estructurados que
One with
tendrán premio y
structured
otro
scientific
que hay
works that
trabajos
will receive an
libres que
award,
también
and
generaremos
then the
premios
free abstract
con
that
participaciones
will be
tanto
participate
en Georgia
in Georgia,
para que ustedes puedan tener
so that
inscripciones y
you
demás
can get
premios
registrations
por sus
and other
presentaciones.
awards.
Vamos a tener
We will have
presentación de póster y ustedes pueden
e-posters,
expresar
and
cómo
you
hacen sus
can
técnicas en
state
5
how
minutos,
do I
tanto
do
sea
it,
en
how
video como en una
your
presentación
describe your
breve.
techniques
También
in
pueden hacer
videos or
su comentario
presentation.
de 500
You can make
palabras
your
acerca
500
de
words
reseñas de
comment
editoriales
about
científicas.
editorials
La fecha de los abstracts,
comments.
como pueden ver acá,
The
los
deadlines,
abstracts estructurados
and see
van a ser
structure abstracts
presentados
will be
el 8 de
submitted
julio y el
in
22 de
July the 8th,
septiembre los
September
abstracts no estructurados.
22nd,
Latinoamérica es un
unstructured.
puente
Latin America
científico
is a
donde
scientific
todas sus
branch
sociedades
where
están
all
brindando
societies are
su mano y
providing,
extienden un puente científico
extending a
al resto de los
scientific branch
continentes,
to the
buscando
rest of the
generar
continents,
controversias a través de
trying
sesiones
to create,
conjuntas y
generate
la importancia de
controversies.
esto
And the
va a ser
importance
muy
of this will
significativa
be
porque
very
va a respetar los
significant
estándares
because it
de
will be
excelencia de
following
UIP.
standards of
Vamos a pedir
excellence of
que los
UIP.
expertos de cada
We
una de
will
esas
have
regiones y
experts
sociedades
from each
sean
region and
especialistas
society
reconocidos para el
to be
manejo
recognized
de esa
specialists
sesión
in the
y
management of those
temas
sessions,
innovadores o de
and then
actualidad. Y por
innovative
supuesto solicitamos y
topical
requerimos una presencia significativa de esas
subjects,
sociedades
and
para
we
que el
require the
intercambio sea más
presence of
fluido y mejor.
societies so that
Este
exchange is more
camino que
fluent
estamos
and better.
desarrollando
The
lo voy a
pathway,
compartir
the
con
road
Sasa
will
y
be
voy a
shared
dejar
with
para que él
Sasa,
haga el cierre
and
y su
he will
presentación
be
de
closing.
Tbilisi.
Yeah. Thank you very much.
Gracias.
After today's webinar and the last 2 webinars, for me is very clear that the scientific spirit in Buenos Aires will very amazing and very high interest between the participants. So now no words we need why our colleagues must participate in Buenos Aires meeting in October and then in Tbilisi after 2 years. So I'm very happy, very interesting webinar and all other monthly webinars which we decided to do. I hope that will also in a very high scientific have the high scientific character and so well presented. So thank you to all participants and of course see you in October in Buenos Aires, but before monthly webinars on the road to Buenos Aires. Thank you very much. And now please about some presentation about Georgia.
Welcome to Georgia, a land of ancient heritage and vibrant culture. Nestled at the crossroads of Europe and Asia, this unique country has countless stories to tell and wonders to visit, spanning millennia.
On behalf of the Georgian Association of Angiologists and Vascular Surgeons, I'm honored in inviting you to consider Georgia as the venue for the 2027 UIP World Congress. It's the nature of our hosting society The country doors are fully open to all the world and for a multi-specialty approach, allowing all the attendees to learn from each other, exchanging experiences while networking in a truly stunning scenario.
Also, in this sense, we remain at your vain world service while waiting for you in Georgia in 2027, whenever you want to join us.
Thank you very much, everybody. Chao.
Gracias a todos. La mano saludando.
Have
Entre
fun,
todos.
Gracias.
Hasta la
Goodbye. See you
próxima.
soon. See you next time.
Bye.
Every great journey begins with a single step, and the road to UIP Buenos Aires 2025 starts now. On March 8th, we take the first step, an exclusive webinar on lipedema and lymphedema. Participate, learn from experts, and be part of something bigger. Prizes, recognition, and knowledge that will shape the future of venous health. And this is just the beginning. Many more events are yet to come. Be part of the journey. Secure your spot now. See you on the road to UIP Buenos Aires 2025.
But this journey, it's about more than knowledge. It's about the experience. Buenos Aires is waiting for you. A city full of history, culture, and innovation. A city where tradition meets the future. And beyond Buenos Aires, Argentina offers breathtaking landscapes and unforgettable adventures. From the vibrant city lights to the wonders of nature, your journey to UIP Buenos Aires 2025 will be an experience of a lifetime. Join the greatest minds in phlebology, lymphology, and athletics. Learn, collaborate, and innovate alongside world leaders in venous health. Your journey starts now with On the Road to Buenos Aires 2025. Exclusive webinars, cutting-edge research, and real-world training. And this is just the beginning. What happens next will change everything. Pre-register today, secure your spot, and be part of history. The future of venous health is waiting for you in Buenos Aires.